Thank you, Julia, thanks for that introduction. I am excited to be here. I've Karen holds a very dear place in my heart as I began to engage in learning about interpersonal violence when I was in medical school, which led us to do a community health project to learn about it in the South Asian community. I and another medical student at UNC, Susan George, and led us to then meet this amazing community of individuals who started Kieran. This is like some of our original paperwork back in 2000. And so I went away for doing all my training and moved back, and I'm so happy to be able to be a part of Kieran again through the speaker series. So today I'm going to talk to you about the scope of the problem and bring in a little bit about how COVID-19 impacted interpersonal violence, why this is a public health concern, and then talk more about the healthcare setting, how we screen and the barriers, and then the concept of trauma-informed care and how to advocate for yourself in healthcare settings, and then some practical tips. So what is the definition of interpersonal violence? It is physical, sexual, or psychological harm by a current or former partner or spouse. It can occur in heterosexual and same-sex couples, and it does not require sexual intimacy. Additional factors associated with interpersonal violence, there's physical violence, where a person is hurting or trying to hurt a partner through physical force. Sexual violence, attempting or forcing a partner to take part in a sex act. This can include sexual touching or non-physical sexual events like sexting when the partner can not or does not consent. Stalking is another form of interpersonal violence, unwanted attention, which causes fear or concerns for one's own safety. And then psychological aggression, the use of verbal or nonverbal communication with intent to harm the person mentally or emotionally or control them. Additional terminology also includes reproductive coercion, so behaviors control a woman's reproductive health choices, intentionally exposing an individual to a sexually transmitted infection, pregnancy, coercion, either to continue a pregnancy or to terminate a pregnancy, and then also sabotaging family planning, for example, not using condoms or not giving permission to use family planning methods in order to plan pregnancies. The scope of the problem is vast. About 1 in 5 women and 1 in 7 men report having experienced severe physical violence from an intimate partner in their lifetime. About 1 in 5 women and 1 in 12 men have experienced sexual violence by an intimate partner, and 10% of women, 2% of men have reported being stalked by an intimate partner. So violence is pervasive, but those who identify as women are disproportionately affected. So I wanted to bring up COVID-19 as an example of how societal stressors can sometimes lead to increased risk of interpersonal violence. You know, the quarantine led to increased risks of violence because people were required to stay the whole day with partners and away from supports. There was isolation, non-private televisits or no healthcare visits when it came to interacting with healthcare professionals. Of course, being in small quarters can exacerbate stress. There was economic stress associated with the pandemic, and notably increased gun sales and substance use. And additional social stress included the school closures, which led to more family stress. COVID-19 also became the source of fear and aggression, that it was this invisible and dark enemy. And with the risks of sudden and depersonalized death, the limited personal freedoms and anxiety and fear of a disease with unknown dangers and risks and no known cure, that feeling of being threatened can lead to a need for aggression, which can lead to interpersonal violence. And I bring that up even though we're not in the midst of the pandemic anymore. A lot of those society changed after that. And I also think that there are major stressors in society that can impact immigrant populations right now with changes that are happening in, our federal government and immigration issues that can potentially lead to similar sorts of feelings of fear, leading to aggression. And so I think that societal stressors can sometimes lead to increased risks. So it is, though, a serious public health concern, and it is a risk factor. So I guess I'm saying that it is an individual concern, but it is a public health concern to all of us in society, because interpersonal violence is a risk factor for poor health outcomes, including death and injury. The impacts on health go beyond the victim, and exposure to trauma can lead to long-term physical and psychological consequences. So in terms of public health statistics, 81% of women with interpersonal violence report more health concerns than other women related to physical injury, post-traumatic stress, asthma, diabetes, irritable bowel syndrome, frequent headaches, chronic pain, sleeping difficulties. 1 in 3 females were killed by an intimate partner in 2021. And the violence can occur at any point in the lifespan. It can start early and span across the lifespan. So children who are exposed to violence may continue to have violence as a part of their lives. And reproductive aged women are particularly at risk for interpersonal violence. Factors that increase that risk include exposure to violence as a child, young age, unemployment, exposure to substance use or use themselves, marital difficulties, and economic hardship. And so the person who is abused is not the only person impacted, right? We have a ripple effect that starts with the victim and goes to their children, to their family beyond. All of us are members of our community and so forth. And so there are health effects beyond the initial victim and long-term effects beyond the incident of abuse. So what is trauma when I use the word trauma? Trauma is exposure to actual or threatened death, serious injury, or sexual violence. It can be direct trauma, witness trauma, or indirect, hearing of a relative or close friend having had a traumatic situation. Traumatic events can include natural disaster, a life-threatening illness, car accident, war violence, childhood abuse, sexual assault or abuse, and intimate partner violence. I think that it's when we think of examples of trauma that are particularly devastating, sexual trauma in childhood and adulthood stand out. But all of these are in the scope that I've highlighted of intimate partner violence, either to the person who is being abused or that surrounding group within the family. So when somebody has a traumatic event, their normal coping mechanisms become overwhelmed. The fight or flight that we classically learn of how our body just goes in tune with danger, that becomes not possible. And individuals feel dread, paralyzing fear, or a sense of powerlessness. And they may be acute symptoms that last for weeks after a traumatic event: anxiety, heart palpitations, nightmares, difficulty sleeping. But it's important to distinguish post-traumatic stress symptoms, which include re-experiencing the situation through nightmares or flashbacks, avoiding thinking about or the places, people, or reminders of the event, having heightened arousal like insomnia, irritability, anger, heightened startle response, or negative changes in mood or cognition, which includes feeling detached or isolated, blaming of self and others, or memory loss. Those are symptoms versus actually having post-traumatic stress disorder, which includes all of those things, but that those things of re-experiencing avoidance, heightened arousal, negative mood, or cognition last for at least a month and also cause distress or social impairment. And so one can imagine how individuals who are experiencing or witnessing interpersonal violence will be at risk for post-traumatic stress disorder. So when there's a traumatic event, it's not that everyone develops PTSD or post-traumatic stress disorder. Most individuals are resilient after a single traumatic event, but a small percentage will develop chronic signs and symptoms of post-traumatic stress, and particularly if they have recurrent events, which are reinforcing the fears and feelings that are associated with the trauma. And of course, past trauma can stay with an individual, as I've described through PTSD, and then lead to intergenerational trauma that, in fact, again, affects that whole spectrum of individuals in contact with that one person. And that past trauma can also then impact current health. So, for example, since I take care of women who are pregnant, PTSD is known to be associated with major depression, substance abuse during pregnancy, self-harm, suicidal ideation, and preterm birth, which means, having a baby prematurely. There can also be associations with bonding with somebody who's had trauma, including trauma during childbirth. There is trauma that then can be, the traumatic events can impact women by putting them at risk for postpartum depression and bonding impairment with their infants when studied at 6 weeks postpartum. And so it's recommended because of these societal and real health risks associated with interpersonal violence that all clinicians should routinely screen for interpersonal violence. The feeling is that the risks of screening are minimal, and screening tools can effectively identify women who are experiencing interpersonal violence. But screening is not enough. Screening alone does not reduce interpersonal violence because we don't have all of the referral systems, the effective interventions, and the follow-up in place in our healthcare settings. And there are many challenges to doing effective screening and then all of the things that need to happen after a positive screen, such as barriers through physicians, patients, and social and cultural barriers. So what are as physicians, what are barriers that physicians carry? The most common ones include personal discomfort, feeling like a lack of knowledge of resources, and then time constraints. There's another patient waiting, I'm not sure what to do. And that leads to personal discomfort and in either no screening or inadequate screening. And so having availability of increased education and training and resources can mitigate some of these. Barriers to implementing interventions in the healthcare setting is that most of the important needs are often unmet by the healthcare setting. So while many individuals may be able to access healthcare settings either because of health issues or pregnancy, the things that individuals who are experiencing interpersonal violence, such as shelter, long-term housing, law enforcement help, financial assistance, childcare, are often not found in the healthcare setting. From the patient perspective, there are barriers and that it's just difficult to disclose. Many individuals have had inappropriate responses from the clinician that they're working with. They may not be comfortable in the healthcare environment. They're not confident in the disclosure to a clinician. Are they going to be able to help? Are they going to keep my confidentiality? And then some concerns, I don't know why that just got really big, but some concerns about reporting to child protective services. If violence is reported in the home, then will somebody tell someone and put my child at risk? So that being said, there are a lot of barriers, and I'm listing them, but I also want to talk about how we can make the healthcare setting better for individuals who have experienced trauma. And that's through a concept called trauma-informed care. And most people who are training right now, and I think that individuals that are especially working in women's health, are being trained and learning more about how do we take care of patients in a trauma-informed fashion. The approach is providing healthcare that is sensitive to the needs of trauma survivors, whatever the reason, in order to normalize the experience of past trauma, recognize that some of the behaviors that our patients might be having that may make the visit, quote unquote, more difficult to get through are actually their coping mechanisms, and putting forth efforts to have a more safe, have a safer environment and avoid re-traumatizing the individual. And then there are non-trauma specific interventions that occur in the healthcare setting, like mental health therapy, that are a little bit that are not specific to how you can set up the healthcare setting in a way that is sensitive to the needs of trauma survivors. That's different type of healthcare, I guess is what I'm saying. So what the goal is that the encounter feels threatening to the patient. You create a setting that is trauma informed so that the encounter can become more relaxed. And while this, again, does not solve the housing needs or financial needs or legal needs of an individual, it can create a setting to allow someone to feel more safe in that very important visit they're having. What are some triggers for trauma in the healthcare setting? Having to take off your clothes. Body positions, for example, having pelvic examinations requiring legs to be open, feeling loss of control, either internally because something's going on in your body and you don't understand it, or externally because somebody is doing something to you. Language that's used. An example that's listed here is relax, don't fight it, or using terminology like open your legs. Like there's a lot of different ways that have been trained not to use re-traumatizing language. Having vaginal exams in and of themselves can be triggers for PTSD. And even for some women, having to have a breast exam or breastfeeding can be traumatizing or re-traumatizing. And so the concept is that we have this concept of universal precautions. We use that like when we're thinking about we don't treat anybody differently because we suspect they may have this disease or that disease, right? We should just like treat everybody the same. And the same thing with trauma. We use these universal precautions with every patient so that like if that person doesn't want to disclose with us, we've treated them in the way they need to be treated. And if they've never had trauma, it also is a good situation for them. So we try to think about environmental considerations. So for example, positioning chairs so the back never faces the door, protecting privacy through modesty, verbal and nonverbal considerations, like I gave examples of, but also sitting at eye level to minimize power differential, always asking before touching, and explaining everything that's going to be done so that there are no surprises. And if somebody has distress, to stop touching. That while healthcare visits can often be rushed and things like that, this is not a time to rush someone who is visibly distressed upon the healthcare encounter. So I've told you what we're supposed to be doing, but it may be that a person is seeing a healthcare provider who isn't trained in trauma-informed care or isn't picking up on signals or isn't doing what you need to feel safe in the encounter. And the number one thing I want anyone to get out of this is that it is okay to advocate for yourself. You are seeking a service when you're getting healthcare, and you have a right to be treated in a way that makes you feel safe. And so, you should consider whether disclosing your history of trauma may make your visit better, because it may help someone understand that they have, even though I'm suggesting universal precautions and we should go into every encounter the same way, it may help somebody be more likely to take some of these things into account. It's okay to ask in advance what will be done so you can be prepared. Let's just say, for example, somebody has an abnormal pap smear and they've been now referred on to get a procedure to look for abnormal cells. And that procedure is called a colposcopy. If you've never heard about it, maybe you have looked it up and it seems horrible from what you're reading online. And you haven't been able to, you've gotten information that's brought fear, it's triggered previous feelings. It's okay to go into the visit and say, I'm nervous about this procedure. I've never had it before and I don't know a lot about it. Can you tell me exactly what will be done? And that is completely reasonable. It's okay to stop the provider and ask them to explain things. Or even if all parts of the exam are necessary, if you feel that those could be traumatizing. And it's okay to share things that might make you more comfortable. Like I would be more comfortable if I didn't have to take all of my clothes off. Like, can I leave my shirt on? Or can I, only take off my shirt and leave my pants on? I'm just, making up examples, but if those things make you more comfortable, or like sometimes people go to a visit and in order to be efficient, they ask people to go ahead and undress. And if that's something that would make you uncomfortable, it's okay to say, is it okay if I wait until, so and so comes in the room? Um, if those are the things that will help you get through that visit and not re-traumatize you, it's okay to advocate for yourself. So that's sort of my ending of like how trauma can be experienced in the healthcare setting and what we can do to mitigate or to advocate in the healthcare setting to avoid re-traumatizing. These things are practical tips that probably most of you have heard before, but I felt like these are the things that I would want any of my patients to know who might be experiencing interpersonal violence, and so I wanted to include them in the talk. I did want to warn that, I will be talking about abusers and violent acts, and that might trigger emotions or bad memories. So if a person is living with an abuser, safety tips at home include preparing yourself. So it may be that you're not at a stage where you're ready um, to leave or separate from an abuser, but it's important to be prepared because things are unpredictable. So practice different ways to get out of your house safely. If you have children, practice with them as well. Knowing some basic defense and disengagement techniques, which can help you avoid violence and feel more confident, is good. So practice what you will do and say in that setting. If you can, always have a phone where you can get to it and memorize phone numbers if you need to call for help. Let friends or neighbors who you trust know what's going on at home so you can make a plan with them and know what sort of help you would like from them. There can be a lot of people who want to help you, but they don't know exactly what's needed. And so making a plan with them to know and potentially having a signal, like flashing lights on and off or hanging something out the window to alert them that you need help. And of course, keep your important papers in your car or a trusted place. And those things include birth certificates, passports, immigration papers, social security cards, just in case you have to leave in a hurry. If you can, talk to a domestic violence hotline, which includes like national hotlines, of course, they're Kieran, so that you can talk to somebody who understands you, even if you feel like you're not ready to leave, just to be able to get this advice and be prepared. And think of several reasons for leaving the house at different times of day or night that your abuser will believe, just because if in case you feel the violence is about to erupt and you need an excuse to get out. If you never go anywhere and then suddenly say you need to go out, that's going to be a red flag. But if you, it also helps you stay engaged with the world and not so isolated. And you may know that the abuser may have patterns to their abuse. And so be aware of signs that show that he is about or she is about to become violent so you can assess how dangerous the situation may be for you or your children. Preparing your surroundings include being aware of anything that the abuser can use as a weapon. So trying to keep sharp or heavy objects away from you. Know where guns, knives, or weapons may be, lock them up or make them hard to get to. Figure out where safer places are in your home, the places where there aren't weapons within arm's reach. Try to get to a safer place if you if it does look like the abuser is about to hurt you. Places that have a lot of potential weapons include the kitchen, garage, workshop. I think this is particularly relevant for South Asian women, which includes wearing scarves or long jewelry, as these can be used for strangulation. And then make a habit of backing the car into the driveway rather than having to back out of it, so it's easier to get out. Making sure there's gas in the car and keeping the car keys in a place you can easily grab. And then if you have children involved, um, create a plan with the children where they're not getting involved if the abuser is hurting you, and deciding on a code word with them. If your children are too young to leave the house, or if the abuser won't let them leave the house safely, figure out a place with them, a safe place for them to go where they can call for help. Make sure that they know their priority is to stay safe and not to physically protect you. And just to help them understand that violence is never right, even if it's someone they love that's being violent. Again, we've talked about intergenerational trauma and how violence that starts in childhood then can perpetuate and create health problems throughout one's life. During a violent episode, trust what you're feeling. If the violence is escalating, trust that. Many times people second guess, and try to remove yourself if you feel like this is the time. Trying to maintain a safe distance, and so avoid getting backed up against the wall. And it's useful to have things between you and your abuser, like a table. And if the abuser does start to harm you, don't run to where the children are. The abuser may hurt them too. And if there's no way to escape violence, make yourself a small target. Dive into a corner and curl into a ball. Protect your face and put your arms around each side of your head, wrapping your fingers together. After a violent episode, seek medical attention, call the police if it's safe, make a police report, file a restraining order if you think that could be useful in your specific situation. Be in touch with local domestic violence organization for support as you need, whether it's shelter, counseling, or other services. And if you're able to take pictures of any injuries, destroyed property or clothing, and save it where the abuser can't find it. So even if this violent episode is not leading you to leave the home that you share with the abuser, you don't know what's going to happen in the future. And so documenting these situations and keeping them in a safe place may help you at a point where you are ready. And then as you prepare to leave, if that's a decision that's been made, make sure you have your plan. One in the case where you have time to prepare and leave the home, and then a second one if you have to leave in a hurry. If you have kids, talking to a lawyer who specializes in custody is very useful to do before leaving. And again, keeping any evidence of abuse and take it with you, and because you don't want your abuser to find it in the times that you're preparing to leave and then escalate violence that could cause more danger. Or you may have to keep it in a locked drawer at work or with a trusted family member. In your bag, things like documents that I mentioned, driver's license, credit cards, money, phone numbers for relatives, doctors, schools, taxis, local domestic violence organization, change of clothing, medication, mentioned legal documents, information about the abuser that could be necessary for future court filings, such as their date of birth, social security number, license plate number, financial documents, evidence, and then important things you would like to keep, like your photographs, jewelry, or other personal items. And it's important as you're preparing to hide that bag, hiding the car keys, setting the money aside, which might mean saving a few dollars per week so that you don't tip off the abuser, considering that protective order, and then leave the abuser when they will least expect it. It gives you more time to get away. And, again, I can't emphasize more speaking to local domestic violence organizations like Kieran in order to get individualized advice. This is very general. So, in summary, we have to recognize that interpersonal violence is not just a problem between two people or within a family. It is a public health problem that impacts our entire society. And it impacts more than just one person, the one person experienced abuse. Societal stressors can increase the risk of interpersonal violence. I gave the example of the COVID-19 pandemic. And in the healthcare settings, we should screen for interpersonal violence, but there are barriers that can be mitigated through good communication, resources, and education for providers. It's critical for trauma-informed care to support women who are in interpersonal violence situations, and those interventions may facilitate recovery and reduce intergenerational trauma, for example, during pregnancy. But we know that providers need more education. And so therefore, can you find ways to advocate for yourself so that you can feel safe in your receiving your own health care? And though you may not be ready to talk to your healthcare provider, there are many resources that they have that can connect you to, or give you practical tips. And so just a reminder, the healthcare setting is a confidential setting, and the intention of anyone who sees you in healthcare is to support you. It's just that sometimes the resources are not there, which leads to discomfort, or the patient is not ready to disclose, but just know that it is a setting that is ready when you are ready, if you are experiencing interpersonal violence. And I will stop there and come take questions.
All right. Thank you so much. I am going to stop the recording now.